So we'll start with some of the symptoms and what other testings that we should be performing when you see a patient that has suspected diagnosis of hairy cell leukemia or clinical presentation suspicious. So I'll start this section with Andrea.
So I think we've kind of already talked a lot about the clinical presentation, and we're alluding in the last section, but kind of the first part of the important diagnosis after you've already had your CBC with differential and taken a look, but is a bone marrow biopsy. And we discussed in the last section, often it is extremely difficult or impossible to get an aspirate, and that's due to the fibrosis that's induced with the hairy cell, as well as some probably interlocking of those hairy cells with the projections. And anyway, the point is that it's very important. You can still attempt it, but you'll get a good biopsy. To then look under the microscope, you'll see the classic fried egg appearance is the classic that I think probably still comes up on boards for many people even. And it's usually a hypercellular marrow. There is a percent, probably less than 10% of hypocellular marrows that are coexist, but it's usually a hypercellular. And then we were just talking a lot about BRAF testing. I will note it has not been incorporated as an NCCN automatic diagnostic criteria, but I think most of us find it's important. One, because it will help if there's any question with the immunohistochemistry to classic variant versus other variants of hairy cell, or we'll talk about the differential in a moment, but then also because it does guide treatment down the road potentially. So, but beyond the BRAF testing, the other thing that's important is your immunohistochemistry testing. So classically, I'm sure we all have seen variants. Hairy cell is pan B cell antigen expression. So CD19, CD20, CD22. And importantly, in distinguishing from other indolent lymphomas, it lacks CD5 and CD10, CD23 and CD27, also CD21. CD103 is a very sensitive marker for hairy cell. And also classically, you have CD11C and CD25. So that's kind of, you're going to find the immunohistochemistry testing is extremely important. The other thing I know that comes up is when to do imaging, and I know I open that up to the rest of the panel, but it's certainly not necessary if you have questions about the spleen or if other things are going on, you're palpating lymph nodes and you're wondering, and certainly it can be useful, but it's not, imaging is not a mandatory aspect of the hairy cell diagnosis.
I would agree. I don't routinely do CAT scans or ultrasounds of people's abdomens. If the patient's on a clinical study and you want to know the depth of response, I think it's a necessary thing to do to see if you can resolve splenomegaly. And about 20% of patients will have lymphadenopathy on CAT scan. But in terms of routine care of patients, I don't see any advantage, especially if you can palpate the spleen. And even if you can't palpate the spleen, I'm not sure it moves the ball very far forward to be able to know whether there's imaging of a spleen. It's not clinically significant.
Dr. Sabin, you talked a little bit about actually something about the prognosis of the patients with the hairy cell leukemia. So we spent some time clinical presentations and diagnostic work that we'll perform. When we see them, is there anything that we can share with our patients that kind of how they would likely going to do in terms of the genetics, clinical age, or anything you consider?
Well, the first thing I tell the patients is you've got the best of the bad bunch. And your life expectancy is very close to that of the normal population. And despite the rarity of this disease, there's a plethora of treatments, and hematologists are squabbling about what's the best of the combination of drugs and which is the least toxic. So the overwhelming majority of patients seem to do very well. We've spoken before that if you're a little on the younger side, below 40, when you get the disorder, there seems to be a slightly more aggressive nature to the disorder, but still very indolent. If your flow cytometric pattern doesn't express all the markers that Andrea alluded to, If you're CD25 negative, but you've got everything else, you may not do as well as everybody else. If you're BRAF negative as opposed to BRAF positive, it may be that you don't have typical hairy cell leukemia and you're not expected to do as well. We spoke about the MAP kinase expression, they tend to do worse. If you've got the V434, they tend to do worse. The size of your spleen, the severity of your cytopenias tend not to affect your prognosis. Patients who present with typical or atypical hairy cell leukemia that have a high white count, they tend not to be as sensitive to the purinucleoside analogs that we're going to discuss later. But the overwhelming majority of patients are going to do exceptionally well and can expect a near normal life expectancy. I don't know if second malignancies is a topic for discussion today, but the incidence is increased. There was a long debate as to whether it's treatment related because the drugs are very immunosuppressive, or whether it's the disease itself, or combinations of the above. But often patients get second malignancies 10, 20 years later, and that's actually the cause of their demise.
How do you frame the conversation with the 35-year-old with hairy cell leukemia? You know, they're looking at a horizon of 50 years.
Again, I started with you should do very well. You're going to become an expert on this disease. You're going to read all the articles. Your disease may be a little more aggressive. We haven't got into treatment yet, but I tend to give them combination therapy with a purinucleoside and an anti-CD20, just that I can try get closer to minimal residual disease. But they tend to do very well, despite the young age. But you're right, they want to know what's going to happen when I'm 60, 70 years old. And they should do well, but not necessarily so, because we don't have a curative approach. We don't think that we can cure this disease, even with all the therapies that are available. So at some point, they're going to relapse.